Hi everybody, today we're going to be talking about a topic that I've been playing around with for the last 3 years, which is incorporating ultrasound into neuraxial techniques. This first part will cover how to put ultrasound with your thoracic epidural practice. The audience for this video will be people who are mostly proficient with thoracic epidurals, but would like to be able to use ultrasound for those troublemaker patients, the obese patients, patients with scoliosis, or there's just the really difficult backs where you just can't find that space and you want that little bit of extra help to just make your success rate a little bit better. So spinal ultrasound for the beginner, part 1, thoracic epidural. And I would say that the stages of using ultrasound, I would say there's the first part, where is where I started, is where you do your usual palpation technique, and then you just add thoracic ultrasound in for your complicated patients. But mostly it's still a palpation technique. The second phase is where you're using ultrasound without the need for palpation at all. And then the third phase, and I would say that I'm not there yet, is when you're doing real-time visualization. I'm not actually sure how many people are doing this. So if we think about our thoracic epidural technique, we're going to break this down into sort of 5 parts and see how ultrasound can help us out with all of those parts. We're going to look at positioning the patient, landmarking, where we put our needle, how we estimate the depth to the space, and what needle trajectory we use. For positioning, we would use the normal position. You want that really nice curved back. The one thing that is different is that with ultrasound, you need the patient to maintain a more stable position for a longer period of time. You don't want to go to all the trouble landmarking that spine and then have the patient move and have wasted all this time. So I usually have the patient supported on some kind of support surface. Mayo stands generally work very well. And then you just want to make sure they get into a really comfortable, good position before you proceed. So how do we landmark? So when I do my blind landmarking, I'll usually use the ilia crest and the inferior angle of the scapula, and I'll mark them out. And then I palpate the midline. That will give me a sense of what level I want to go at. And then the midline, of course, will tell me how far from midline I have to do my needle insertion. But that would in essence be my blind landmarking. How can ultrasound help with that? So ultrasound can definitely help us find the midline in challenging patients. It's a very easy first start. And if you only start with that, that already will be very helpful. So how do we find the midline with ultrasound? So you have the patient either sitting or in the lateral position. I prefer sitting. You use the curved probe. You have that in a transverse position. And one of the things that I've seen that people do is that once they're on the spine, the probe kind of tends to tip one way or the other if the spine is a little if the spinous processes are a little protruding. So you want to make sure that you keep that probe really straight so you don't have angulation in the probe. So you keep that probe very straight on the patient's skin, like perpendicular beam going down into your patient's back. And then on the screen, you'll identify the spinal structures. So the bare minimum that you have to identify is really only to find symmetry. So you'd put the M mode on the ultrasound and then just find symmetry around that beam. Whether you can identify the structures or not is not as important. The basic structures that you would see at this point would be the spinous process and the lamina. And because the lamina are bony, you don't see any structures distal to it, as the ultrasound beam can't pass through the lamina, so you would have this big shadow forming behind it. So in essence, you put the M mode through the middle of the picture, make sure you find symmetry around the M mode, and then you mark the skin at the middle of your probe. And once you've marked it, this is kind of what it will look like. I usually mark in about 2 or 3 spots, because this will tell me whether the spine is straight or whether I have some kind of curvature like a scoliosis. So that's the first step in learning the technique, and that can really help you with midline in your obese patients. Something you can also take into your lumbar practice when you're doing lumbar spinal epidurals is that first step in just identifying midline. So find that spinous process, put your MO through it, mark the middle, look at the middle of your probe and mark the skin at that point, and that is your midline. And we know how important that is in terms of regional. The next step, which is a little bit more challenging, is going to be to find our interlaminar gaps. So that's going to help us to, at our next sort of level of practice, trying to fine tune where our needle is going to go. So how do we do that? This time we're going to have our curved probe again. We're going to have it in the sagittal position, so up down, and our indicator is going to be cranial. So if you're looking at the spine, there's a couple of places that probe could be if it's in the sagittal plane. It can scan ribs, it can scan transverse process, the articular processes, or over the lamina. And they all look a little bit different. I want you to have a little look at the how flat the lamina are here in the thoracic spine. And how sometimes it's even overlapping, so that you're not going to really visualize those gaps very easily on ultrasound. And so here's what you might see. So on the top left here, we have the ribs with muscles overlying. Then as you become more medial, you get your transverse processes. Then you're getting the articular processes, and then if you come in even closer, and likely with a little bit of an angulation on that probe into medial to kind of be perpendicular to the lamina, you will see that. Now, one of the things that originally tripped me up is that when we do lumbar scanning, we see more of a saw-toothed presentation of our lamina. But in the thoracic spine, that is really the articular process, and you have to come in even more medial to get the lamina. So you would generally see this fairly flat lamina with a small space in between and the posterior complex in between. And sometimes as they're overlapping, it's very difficult to see even any kind of gap. So you don't always see the spinal complex, the posterior anterior complex, with a thoracic scan. So this is what it will look like in real time. Then you'll have your patient nicely positioned. You'll have your curved probe in the sagittal position. You'll have your indicator cranial. You'll use your M mode on screen. You put the M mode through that interlaminar gap, and you mark the skin at the middle of your probe. And once you've put the mark, that is what it will look like. These are all pictures of the skin to lamina here. And if you do a perpendicular line from the probe to the lamina or the interlaminar gap, that would be the distance that you would usually get when you put your needle down perpendicular and you hit bone. So that is the minimum distance. You know that the epidural, the loss of resistance, will likely be 1 to 1.5 centimeter more than that, depending on the angulation of your needle. So as we can see, the difference between this red line and that red line is the straight versus the angled approach. But to get that minimal distance, you can use ultrasound instead of your needle. When I've marked my back, it will look something like that. So I will mark my midline, my paramedian, my interlaminar spaces, and I will usually pick my lowest acceptable level, which is my longer line. So once we've done all of this, we now have to decide, where am I going to put my needle? And this is actually probably the part that I still find somewhat challenging sometimes, because even though I've identified all the landmarks on the spine, there's still an angulation component that can be tricky. And there can also be hidden osteophytes that you can't see with the ultrasound, and they can still cause obstruction to the passage of the needle. So it's not like you're scanning and then you put the probe down and the needle always just slips in. It's certainly easier and you know more where you are with your needle, but there's still a little bit of digging around. So what are our options? So when you're just starting out, you can use this to landmark your spine just to get a sense of where things are. And you can still use that traditional blind landmarking approach where you take the tip of your spinous process, go out a centimeter down, go down to lamina, and then angle up and in. The other option, which is what the Toronto Western group advises, is to do more of a parasagittal approach. And so what they do is, once they've landmarked out their space in their midline, they go 0.5 centimeter from midline, and then they drop down 1 to 2 centimeter. They then angle about 50 degrees up and 5 degrees in, and go down to find the space that way. My approach is I do all these markings. I try and find the best view of the interlaminar space, and I use that as my paramedian line of entry. And then I plan my trajectory based on how deep I see the lamina. So depending on how open the space is, how deep the space is, how much I think I will have to go in under a lip, or how open the space is. Sometimes if you see a really open space, you can do a very direct approach, and it's actually, you don't need much angulation at all. So I individualize my approach. The parasagittal approach on Toronto Western is definitely a good place to start your journey. So this is what I will do. I will mark out my midline. I will mark my paramedian, which is my best line view of the lamina and the interlaminar gaps. I'll pick my interlaminar space based on how deep the lamina are from skin and how big the interlaminar gap is. I'll plan my trajectory. I will pick a needle entry point. I will pass my needle. And as you can see, it ends up being a fairly parasagittal approach in terms of the angulation. I am not very far out, so my angulation to midline is probably not more than 5 to 10 degrees, which is what the Western group recommend. One of the common mistakes in thoracic epidurals is to have too steep an angle to midline, and then you cross over midline and end up in the paraspinous muscles or even the paravertebral space on the contralateral side with a loss of resistance that can be confusing. So not angling too much to midline is probably a good way to make sure that you're staying on the side where you think you are. So that in essence is the technique that I use. I position the patient as per usual. I then I use my ultrasound in the transverse position to find midline. I then turn it in the sagittal position, find my paramedian line and my interlaminar space, calculate my insertion point and trajectory, and I'll complete my epidural. So what are the benefits of doing it this way? My personal experience is this, that I have less digging around time. So in the more challenging backs, I have fewer first time pokes and fewer redirections. In the really hard backs, it does save a lot of time, and I feel safer knowing where I am. It's definitely helpful in training as well. When you landmark the back out and that resident starts digging around, you kind of have a sense of where the needle tip is, which is quite reassuring. Thank you for watching. I hope you enjoy your journey exploring ultrasound in the spinal region, and that your thoracic epidurals will all be very successful from now on. Thank you for watching.